Our last speaker for the Candida block is going to be Neil Clancy. Neil is at the University of Pittsburgh. He's the chief of ID at the Pittsburgh PA, and he has been instrumental in all of the diagnostic studies, beta-glucan, T2, and he's going to give us an update on Candida diagnostics.
Well, great. Thank you, Luis, and thank you for the invitation to speak. There we are. So I'm Neil Clancy, or as the U.S. government knows me, Cornelius Clancy. And I hope things go better today for me than they went at the UN yesterday for our leader. So if you didn't laugh, you'd cry. Here are my disclosures. I've taken money from most of our supporters of this meeting. Just to mention T2 Biosystems, I will be talking about the T2 Candida assay. So let's start with a case from the University of Pittsburgh. This is a 64-year-old man underwent a right extended hepatectomy with a Roux-en-Y biliary reconstruction, a choledochoduodenostomy, for what ultimately proved to be a non-hepatic liver mass. And this surgery involves two anastomotic sites that are prone to leak and complication. And in fact, he did well for about 2 weeks postoperatively. He got the antipyretics of choice early on, which are our vancomycin and piperacillin cocktail. He's doing well, though, at 2 weeks when he develops new fevers and worsening leukocytosis. He gets a scan. He's lying on his back here. Right here, this little bird's beak is dye extravasating from the small bowel into the biliary tree at one of those sites of anastomosis, so he's got a perihepatic abscess. This undergoes surgical drainage. The ID consult service is called, and I won't ask for hands or anything, but people consider the clinicians here, would you start at your institution typically an antifungal agent in this setting? So at Pitt and UPMC, University of Pittsburgh Medical Center, he got started on fluconazole. He gets a T2 whole blood assay that's positive for Candida albicans, Candida tropicalis. His abscess culture shows E. coli and vancomycin-resistant Enterococcus. His blood culture shows the E. coli, and both of these cultures are negative for Candida. So now what are you going to do? Well, you're going to change the gram-positive coverage, or are you going to continue your antifungal, or possibly change it? And to answer this, you have to say, well, then what is the likelihood that I have invasive candidiasis, or particularly abdominal candidiasis in this case? And again, you can think about what your answer would be. Is it really low, middling, really high? Or given the conflicting data, who the hell really knows? So with that, let me go through what I'll talk about. I'm going to review diagnostic tests for invasive candidiasis. The real meat of my presentation, though, is going to be considering how we might interpret non-culture results and incorporate them into rational patient management strategies. And I'll conclude by providing at least some of my thoughts about what studies might need to be done in this space. So in order to diagnose something, you have to understand the disease, and we talk about systemic candidiasis or invasive candidiasis. It's a spectrum. Most of our historic attention has been focused on bloodstream infection and candidemia. About half the time, candidemia is going to be complicated with end-organ infections. But there's another entity that historically has gotten less attention, and that's primary deep-seated candidiasis, where disease doesn't stem from hematogenous dissemination, but rather direct introduction of Candida to a normally sterile site. And this most commonly is going to be the intra-abdominal cavity. So this distribution is going to differ by center. So you need to know your local epidemiology. French ICU data, for example, though, described approximately equal numbers of patients in each of these three groups. So what we teach our fellows is that candidemia is a low prevalence disease among large hospitalized patient populations, right? Broad spectrum antibiotics, IV access, TPN, Candida colonization. A lot of our patients have these risk factors. Intra-abdominal candidiasis is the paradigm of deep-seated disease, has these risk factors, but then also has risk factors specific to the GI tract, and in particular, upper GI tract pathology. So this is a higher prevalence disease among more narrowly defined hospitalized patients. So how do blood cultures actually then perform across this spectrum? The important thing to realize is if you get a blood culture during active candidemia, it's actually pretty good at detecting Candida, and there's no evidence that molecular assays are actually superior to blood culture. So active candidemia, you'll get almost all of them if you're sampling during bacteremia. However, if you have end-organ complications and the bacteremia has cleared, then you're going to miss them. So the sensitivity here is only about 40% from autopsy data. Here, if you have primary deep-seated candidiasis, about 20% of these patients will have a secondary positive bloodstream infection. So if you go across the spectrum of disease, the overall blood culture sensitivity is about 50%. So the mission is finding the so-called missing 50% that culture-based diagnostics are not getting. Well, how about if you go directly to a site of infection and you do biopsies of deep tissue sites? Here are pictures from our mouse model of intra-abdominal candidiasis. And what you can see is you get punctate areas of candida involvement. You get a necrotic core within abscesses. So if you don't happen to sample where the bug is, you'll miss it. And overall biopsy culture is probably on the order of about 40%. And moreover, a lot of our patients, we can't do these invasive procedures. So with that background, there's been great interest in non-culture diagnostics. I'll run through some of the assays quickly. In Europe, in particular in Spain, there's been use of a Candida albicans germ tomb antibody. If you look in candidemia, sensitivity ranging from about 50 to upper 90%, specificity of about 60 to 100%. And as a general theme, it appears that the sensitivity and specificity probably are a little bit lower in deep-seated candidiasis, particularly abdominal candidiasis. Also in Europe, there are Platelia assays, Manan and anti-Manan IgG detection assays. Used individually, meta-analyses would suggest sensitivity and specificity of about 60 and 80 to 90% respectively. If you combine the assays, sensitivity increases to about 80%, specificity of about 80%. There's actually very limited data for these assays in deep-seated or abdominal candidiasis, but the limited data that are out there, this is a multi-center study from Spain, suggests that performance is actually quite poor. So in North America, most experience in the non-culture space would be with beta-glucan detection, the Fungitel assay in particular. A number of meta-analyses done in the early teens basically came to consistent conclusions for invasive candidiasis, approximately 80% sensitivity and specificity respectively. But of course, in individual studies, results may differ. If we look at the smaller body of data, this is largely candidemia data in the meta-analyses, looking specifically at deep-seated candidiasis, and again, this is overwhelmingly abdominal disease. We see sensitivities ranging from 60 to 80%, and specificities generally in the 70s or 80s, with one sort of outlier here at 60%. So again, seemingly a touch lower than what's been reported, at least in the meta-analyses for candidemia. So the thing to realize, of course, is that true positives are not specific for Candida. You'll detect other fungi. And for all the assays I've talked up to this point, you're not going to get species identification. But the major limitation with beta-glucan, as you're all well aware, is the potential for false positivity. And a number of risk factors associated with false positivity have been identified, and these are incredibly common in the very patients who you want to test for candidiasis. People who are colonized, people who have disruption of the GI tract or getting broad-spectrum antibiotics, et cetera, et cetera. So in its extreme, if you use it in a low-prevalence population as surveillance screening, similar to what you do with a galactomannan, and not based on symptoms or suspicion of disease, and the paradigm for this would be, say, lung transplant recipients. This is a study Barb Alexander published in 2010. What you find then is positive predictive values with that type of usage really on the order of only about 10%. So the test used that way does not have utility. So in a sense, the holy grail, I think, of ID diagnostics and fungal diagnostics have been nucleic acid-based amplification and detection strategies. And Candida PCR has a long history of research. Thousands upon thousands of patients have been studied. And the real challenge here is that there's terrific heterogeneity in assays, blood fractions used, patient populations. It makes it very, very difficult to interpret the literature. So the best study that's out there is probably the AVNI meta-analyses that was published several years ago now. And what they found in this study across all the published studies is that if you had proven or probable invasive candidiasis versus at-risk controls, the pooled sensitivity and specificity was about 90% and 90% respectively. And it was far superior to what was detected with simultaneously collected blood cultures. So you will identify at least some of the missing 50%, seemingly with nucleic acid-based strategies. An important thing to understand, if you broaden the comparison, though, and you include possible invasive candidiasis, as well as just the proven and probable, your sensitivity is going to drop to here about 73%. And understanding the diagnostic literature, what you have to realize is most studies are excluding the very problematic patients who you have to interpret results in the clinical setting. So if you take proven versus none, you'll get better results than if you include that middle ground where it's possible disease and the results are much tougher to interpret. So how about PCR and deep-seated candidiasis? I think the first study to look at this particularly specifically was done by my colleague Nguyen at Pitt, and this was a VeraCore assay for Candida detection, the 5 big species. Mark Wissel is in the audience. He really was instrumental in developing this. And what Hong found in deep-seated candidiasis, and this was almost all, again, abdominal infection, sensitivity for the PCR assay of 90%, specificity of 80%. And the simultaneously collected blood cultures were only positive in 17% of patients. So this is great. And 2 years later, a Spanish study looking at a multiplex real-time PCR assay, detecting, again, the big 5 Candida species, had even better results, 90% and 98%. So it looks like things are great, and we're moving right along. But then 2 years later, another Spanish study using basically the same assay, exceptional sensitivity again, 85%, but in this study, specificity of only 33%. So it's across the board. Pick the results you like. I think we really can't say in deep-seated disease where we are with PCR specificity. So with that, enter T2 Candida. This is a whole blood assay done in a self-contained desktop system with about a 4-hour turnaround time. You pop the whole blood tube in. It'll detect the big 5 species and report them as positive for albicans or tropicalis, glabrata or krusei, or peropsilosis, so you get one of 3 readouts. And it was FDA cleared for diagnosing candidemia based on the study published here in CID called the DIRECT-1 trial. And in the DIRECT-1 trial, over 1,500 patients had whole blood cultures that were collected. Only 6 of these patients, though, actually had a positive Candida blood culture. So there were 250 spiked contrived samples with different Candida species, but this was largely then a spiking study. And the sensitivity and specificity for this, which led to FDA approval, were 91% and 98% respectively. But because there were limited clinical data on real patient samples with candidemia, a follow-up study was conducted called DIRECT-2, and this was just published earlier this year at 14 US centers. These were 152 patients who were proven by what was called the diagnostic blood culture to have candidemia due to one of the 5 species that the T2 assay will pick up. 48 to 72 hours after the initial diagnostic culture is positive, patients are identified, and then they're enrolled, and simultaneously a companion blood culture and a T2 sample are collected. So the primary endpoint in this study was clinical sensitivity. How did T2 do based compared to the companion blood culture simultaneously collected? And here the clinical sensitivity was 89%, so basically identical to what was seen in the spiking study. To point out, however, there were 4 patients in whom a blood culture was positive, and the T2 was negative. So if we look at the entire cohort of 152 patients who were originally candidemic on the diagnostic blood culture, what we find is that 45% of these patients had a positive T2 versus only 24% who had a positive blood culture. And in fact, T2 Candida identified 37 patients who were missed by the companion blood culture, so T2 positive, blood culture negative. And then you also had the 4 patients I mentioned earlier who were blood culture positive but T2 negative. And if you look at who the patients who had the discordant T2 positive blood culture negative results were, these were patients who were receiving prior antifungal therapy. So suggesting that fungals inhibited your culture positivity, but T2 nucleic acid detection was still positive. So the test may have a role in preemptive, empiric, or prophylactic settings when cultures might be blunted. So with any non-diagnostic then, given the inadequacy of blood culture, the critical question is what is the significance of these discordant results, in particular non-culture positive, blood culture negative results? So we took 32 patients from UPMC who were enrolled in the DIRECT-2 trial, and the mortality within 30 days was 19%. 6 of these patients died. So if we stratified outcomes by the combined T2 and blood culture results at our center, what we found is if you had a positive T2 or blood culture, mortality rates were 33 to 55%, whereas if you look at the patients who, upon enrollment, were negative by both tests, the mortality rate was only 5%. So looking at the data a different way, if you look at the graph here, if you were T2 positive, 40% died versus T2 negative, less than 10%, a trend towards significance. Similar results with blood culture negative, blood culture positive, blood culture negative. And then if you consider either T2 or blood culture positive versus both being negative, you get a significant 0.02 difference in mortality, 42% versus 5%. So it suggests that the combined blood culture T2 positive results do predict outcomes. T2 positive blood culture negative results are associated with bad outcomes, indicating that you're either diagnosing unrecognized candidemia or it's a marker for some other host factor that's going to be associated with bad outcome. And T2 positivity predicts poor outcomes has also been published by the Spanish group earlier this year in JAC in a small study. And there's a number of abstract data. Pete's presented data. The Michigan group have presented data. So this really seems to be a real biologic marker for something that happens in patients. So just to say, my boxes have gotten screwed up here, but we really have no data beyond anecdotal case reports for deep-seated candidiasis with T2 candida. And then this table just summarizes for candidemia and deep-seated candidiasis the performance of the different assays. Nguyen and I have published some review articles with these type of tables, so you can look those up if you're interested in getting them. Okay, so to the most important part, how do we interpret these results? Can we rationally use them in patient management strategies? And to do this, we're not interested in sensitivity and specificity. We're interested in positive and negative predictive values, and we have to use these tests as Bayesian biomarkers that assume some likelihood of disease. And as a clinician, then you have to use your clinical judgment to make treatment decisions based on these probabilities. So what's nice about both candidemia and abdominal candidiasis is that the prevalence of disease in various clinical settings is fairly well described in the literature. You can also go to your own centers and figure out what these rates might be. So if we look at candidemia, in the DIRECT-2 study, any patient who had a blood culture for any reason, I'm sorry, this is DIRECT-1, 0.4% of those were positive for Candida. And then you can go through different populations. Let's say you use one of the prediction scores, say Luis's MSG score or the Australian prediction score. You can get prevalence of about 10% in those settings. And sepsis comes in at about 3 to 5% typically. And similarly for intra-abdominal candidiasis, you could define low-risk groups, let's say peritoneal dialysis patients with evidence of peritonitis, through higher risk groups, necrotizing pancreatitis. Or as in our case, a presentation, complicated GI surgery, upper GI tract leaks or problems. And they'll have about a 30% prevalence. So if you know the prevalence, you know the pretest likelihood, you know the sensitivity and specificity, you can calculate positive and negative predictive values based on the published data for each of the tests. And I won't walk through all of these, but simply to say that as your pretest likelihood goes up, your positive predictive value increases, and conversely, your negative predictive value is going to decrease. However, you'll note the negative predictive values, at least for the candidemia calculations here, remain very, very strong across your patient groups. So how do I use this? And the problem is we don't really know what the threshold that justifies empiric preemptive antifungal therapy is. If you look at the bone marrow literature, you look at the old critical care literature, it would suggest that a 15 to 30% disease rate, you're probably justified in giving antifungal prophylaxis, and you'll prevent invasive fungal infections. So if we say that represents at least a beginning target to be tested, it would suggest that your target positive predictive value of somewhere 15 to 30% is what you're after, and then conversely, your target negative predictive value would be greater than 85%. However, I'd submit it's probably going to be more in the 90s because you're probably not going to be willing to accept a 15% false negativity rate. So how would we use this then? And here's a graphic demonstration, right? If we have pre-test likelihood and post-test likelihood, and you're not doing any testing, then you've got a straight line, and these numbers are identical. You're going to assign some threshold that you would institute empiric or upfront therapy. This is drawn at 15%, maybe you draw it at 30%. You'll have to decide where you're going to draw it. Then you want test results that are going to take you from below your threshold to then above your threshold with a positive result while maintaining excellent negative predictive value. So if you go through that and you draw your a box then where you actually accomplish that aim, it's within sort of this area. So at very low and very high pretest likelihoods, the tests may not actually help you in clinical decision making. You shouldn't even be testing these people, and these people you may just treat anyhow regardless of result. So if we go back then to the tables we constructed earlier, where are the patient populations where you're achieving this march up above your positive predictive value while maintaining your excellent negative predictive values? And as your assays improve in sensitivity and specificity, you broaden these populations. So for beta-glucan, we might expect it's only going to work in the highest risk group for candidemia, say a prediction score positive patient. If PCR, in fact, is superior to beta-glucan, you may start adding in your septic shock patients. And if truly T2 Candida is 90 and 98% sensitive and specific respectively, you might actually then even broaden to other ICU patients. But if you just use it indiscriminately in everyone, your positive predictive value remains low. Your negative predictive value is excellent, but you're already starting with an excellent negative predictive value in essence. So it offers you nothing. Okay? Doing the same exercise with intra-abdominal candidiasis populations, beta-glucan, high and low, you're not going to have utility, but there may be sort of this emergent surgery group or the pancreatitis group where you'd predict it could be useful. But again, if you've got the Pittsburgh Nguyen experience with PCR, you're going to broaden this. If you've got the original Spanish experience with PCR where it's 90% plus sensitive and specific, you could probably use it in almost anyone. But if in fact the specificity is only 33%, then the test has no value. So it's crucial that we understand the specificity of the nucleic acid tests in non-bloodstream infections. All right, back to our case. What's the likelihood of invasive candidiasis? Postoperative leak at 2 weeks would put it at about 30%, but we do have negative abdominal and blood cultures. They're not great tests, but they do reduce your likelihood. So we're probably at a 12 to 15% likelihood before we do the T2. If it works like the Pittsburgh Nguyen abdominal PCR, then the positive predictive value is going to be about 25%. Negative predictive value is still excellent, about 3%. So the test would help you here. That would probably justify treatment. Fortune, the first Spanish data, it's a no-brainer. This is a grand slam. You treat, a negative test effectively rules the disease out. But if it's like the second Spanish study, then it's worthless. You're just basically at what your pretest likelihood was. Okay, so the epilogue to our case was that he had a complicated course. He had more recurrent leaks, more abscesses. Subsequent intra-abdominal cultures actually grew the Candida albicans, so presumably that was a true positive. He got treated with multiple courses of antifungals and further surgery, but died of septic shock. So when you think about managing individual patients, the good news is you don't need to do the math. Or for our UK friends, you don't need to do the maths. You can use this like a galactomannan, right? I have a high-risk patient. A positive test probably justifies treatment. I have a patient who's at low risk. Negative result actually means I can safely not give the drug. So I think an impressionistic approach in individual patients works. At a population level, the question is, can you devise then rational intervention strategies? Can you use positive results to either institute therapy or negative results then to either not institute therapy or discontinue empiric therapy once you've started it? And I think these are questions we're going to have to answer. So at Pittsburgh, Huang and her team, diagnostic stewardship team run through the antimicrobial stewardship program, have taken unit-specific approaches, different patient populations, different Candida disease states, and tried to come up with unit-specific algorithms. So here's our medical intensive care unit septic shock algorithm. And here are the various assumptions of what the underlying prevalence would be, and then positive and negative predictive values. But basically, positive tests justify continuation of empiric therapy. Negative tests mean that you can discontinue therapy. And you fold your culture results into this as well. So here are the preliminary data from that one unit, the first 125 patients. And what we found is that blood culture positivity was about 6%. T2 positivity was about 10%. So the discordant T2 positive blood culture results were seen in about 6% of patients. And if you take either the blood culture or the T2 positive result, it was about 12% of patients. So we doubled the number of patients who would have been identified with blood culture alone. If you assume the sensitivity is 50%, that's pretty well spot on what you would have anticipated in terms of test performance. In the blood culture positive cases, 4 were T2 positive. However, remember, there will be blood culture negative cases, and the adjusted specificity was 97%. And we showed that there were 47% reduction in antifungal utilization with this algorithm. So I'll conclude in the last minute. What do I think needs to be done? I think we need studies on standardized, readily available commercial PCR amplification assays. Ideally, these would be multiplex with bacterial pathogens. We need to understand how tests are going to do for deep-seated candidiasis, in particular blood culture negative cases. I think we need to think about how we can fold these into empiric treatment strategies. There's been a large body of literature and even editorial saying empiric treatment for invasive fungal infections in ICUs is dead. I think that's not true, and the reason I don't think it's true is the pretest likelihoods have probably been too low in those studies. If you fold a diagnostic on top of this, I think you get into the fat part of the curve with positive predictive values that perhaps make empiricism work. And none of the studies have looked at de-escalation based on negative non-culture diagnostic tests. So you could also take some of the host susceptibility stratification that Mihalis talked about down the road. I think we need to know more about cost effectiveness and more about test kinetics. You know, can the response to therapy or prognosis be done by how this test evolves over time? And in this case, you know, maybe you'd be able to identify patients who could get short course antifungal therapy. Or maybe this could be utilized to enroll patients or follow patients in clinical trials. So I think really we are entering a new era where improved outcomes for candidiasis really are going to come from both drugs combined with diagnostic and intervention strategies. I think in the Candida field, our model really needs to be aspergillosis, where they took a disease with 80% mortality and using drugs and aggressive diagnostic strategies have reduced that. So with that, I'll stop, other than to thank my colleague Nguyen at the University of Pittsburgh, who's really implemented a lot of this work on the ground at Pitt, and Ryan Shields, the pharmacist in our group, who's done it as well. Thank you.
We do have time for one or two questions, if there's anything in the audience. Lisanne?
Hi, Lisanne Porofsky, Bronx, not Yankees. That was great. You know, I would have treated that patient, and I'll tell you why. Firstly, I'm really concerned in abscesses, and so what you're calling deep-seated sites, that Candida can enhance the virulence of the other organisms, like, you know, when they get together. Yeah. And the second thing is, I'm not that enchanted with the blood, and I guess that's my crypto experience. You know, disease is happening before the organism makes it into the blood, I think. And I mean, we just lose too many patients like this, and we get into too many arguments in the unit. And so I guess I sort of see the possibility for a synergistic process that makes the patients really sick. Now, usually they need to go back to the operating room and just have the whole thing taken out. But I've tended to be, I've tended to treat patients like this.
Yeah, no, you're absolutely right on every account. So the paradigm at the University of Pittsburgh, as in this case, that patient got treated. And we would treat all those patients with anastomotic leaks, upper biliary tract leaks, 30% incidence of candidiasis. You treat those people. You could even argue that testing in that population probably isn't even worthwhile. You should just treat those people regardless of result. That might be the high-end population when you're defining your window of utility that you decide just to exclude from testing. And blood cultures in that setting are basically worthless, you know, for the reasons you point out. There's definitely, I think, a potential for synergy. 2/3 of these patients have bacteria recovered at some time as well from an abdominal abscess if they have Candida. And, you know, it's your enteric pathogens, it's your VREs, and your Enterobacteriaceae. And we see a lot of MDR Enterobacteriaceae co-infecting in this setting as well.
Could you address the economics of this? What was the cost savings to the pharmacy versus the cost to the lab for the testing?
Yeah, so I mean, I had to race through it at the end, but I mean, clearly there are studies needed on cost effectiveness. At the University of Pittsburgh, for what it costs us to do a T2 assay, it's a break even in what we save in antifungal costs. In a larger institutional sense, when you take all the silos, we think we save a lot more money because if you shorten unit time, if you shorten complications, particularly in transplant recipients, you save a ton of money. The problem, of course, with hospital administrations is that you look at a pharmacy budget, you look at a lab budget, all the other savings you get are very difficult to sell administrators on. So we think good medicine saves money. As the echinocandins come off patent and become cheaper, then that simple nuts and bolts, you know, drug utilization benefit becomes tougher to show. The other thing that you don't factor in is all the free labor that they get out of Hong, Ryan, the diagnostic management team, and myself to make this program work. And that's the other thing I'd say is that none of these tests are going to work by just plugging it into the lab and just letting it run. It requires a lot of attention to the lab, and it requires teams on the floor actively engaged in ordering, collecting results, interpreting, and implementing decisions based on that. You can't rely on the unit teams to do it on their own. So I make a prodigious amount of money, so that would throw your economic analysis out the, out the window.
Neil, during the last thank you for an excellent presentation. During the last 2 years in the New York Presbyterian Hospital, we've implemented in the adult medical intensive care unit a prospective study of linking T2 Candida biosystem with a very simple protocol where we've carefully tracked and worked with all of the fellows, that if you think sepsis, start the antifungal and draw T2. Very simple. We could have easily generated massive numbers of inclusion-exclusion criteria. Yeah. We didn't, because in the midst of a 2 a.m. Blood draw, you're not going to be thinking that through. The adherence with that was approximately 50%, meaning that others had conventional blood cultures drawn, but never had the T2. Over that period of time, we've now shown, and this has not been shown to my knowledge previously, significant improvement in survival on the T2 coupled with antifungal outcome compared to the conventional blood culture, and significant decline in length of stay from 35 days to 25 days. So we're very encouraged by this. When we looked at the cost, however, the cost of antifungal was trivial. When the NYPH Quality Assurance Group looked at it and said, it's really not contributing much. So the question is, what is the role for cost, really, when you figure in antifungal in a $10,000 per day ICU stay? And my second question would be, what do we do in terms of stewardship? Because that turned out not to be a benefit, because all it took was one negative T2, one positive blood culture, and no one could say, no, the ICU culture was such that we can't count on it. Question.
Yeah, no, great points, Tom. You know, so we presented this to our group, and what our boss said is, wouldn't you achieve the same thing from a stewardship perspective without even doing the testing? Just have a dedicated team interacting on a case-by-case basis. You know, Hong or a team could do that. And in fact, that doesn't work. What the test gives you is something to come to people so they can feel comfortable with your recommendation, particularly to stop antifungal agents. So, you know, as good as, say, Hong's relationship is with the transplant surgeons, you can't fight every battle. And to call up and say, I don't think this guy has, you know, invasive fungal infection, stop the empiric agent. If you don't have something in hand, it's really, really, really tough to do that. Yeah, I think your point from the stewardship perspective's, you know, spot on. I'm not aware of any outcome, mortality, survival benefit. That would be terrifically important. Our numbers have not been sufficient, I think, to show survival benefit. But if it's there, you got to get out there. And you know how hard it is to show any sort of survival benefit in this patient population. It's one of the challenges with the empiric treatment arms, right? So if you've got that, I think that would really be eye-popping.
Thank you.